launch into a rather lengthy question, but I want to cover a lot of this because it's, I love that this person wrote in. They said, hello, I'm a faithful listener to Autism-Live, and I'm so grateful for the incredible amount of useful information and resources that you provide for families and professionals. They go on to say, I am a pre-K intensive teacher.
That's
so this is
lovely.
why I love this, right? That works specifically with 3 to 4 year old severely autistic students. I have a student who is 3 years old, nonverbal, non-responsive to commands or directions, problems with speech and language, prefers to be alone, and needs maximum prompting to do simple tasks such as lift a spoon to his mouth, pick up a marker, follow along in the hallway, or play with toys appropriately. The one thing he does do consistently and constantly is self-stimulation. He wears a diaper and pulls his penis above his diaper and is constantly touching himself or pulling on his penis. His mother puts long shirts on him so that it's not so obvious all the time. This does provide him modesty, but it also hides his hand as he is self-stimulating. He does this action at any given opportunity. I have noticed that he seems to suffer extreme anxiety in the classroom, almost to the point where he acts like a zombie. It is extremely difficult to get his attention and focus. He will put his hands in front of his face as if to block the sensory input, and they tremor in front of his face. How I have managed this is that I will pull his diaper up, place his penis back inside, and pull his pants tighter. Because he's already so anxious, I'm not trying to make him feel more anxious by reprimanding him over an action that clearly is bringing him some level of comfort. During nap time, he will lay on his stomach and hump the mattress and breathe heavily. He does not like to nap and will resist heavily laying down and relaxing. I'm sure the self-stimulating behavior is in preference to sleeping. I'm going to make the assumption, based on his actions, that he is rubbing his penis against his diaper and is self-stimulating either to relax himself, entertain himself, or in preference as opposed to sleeping. I have spoken to the parents about this, and they are well aware of his self-stimulating behavior. They say when he gets home, the first thing he does is take off his clothes and walks around the house with his hand on his penis constantly. They do little to stop the behavior. Some of this is cultural, also because they come from a warm climate, third world country where it is normal for young children to be nude or semi-nude. The parents are not very knowledgeable about autism or behavior therapy and are not resistant to it, but are not very proactive about it either. My dilemma is how to manage this behavior more effectively in the classroom and not add to his anxiety. I wonder if it is a losing battle since the parents do little to curb the behavior at home. And she wrote, help.
What a wonderful person.
Exactly.
You're a fantastic teacher to care so much about this child. I have lots and lots of comments about this, so I'll try to go back, and I tried to mark as you were reading, but there's a lot to give feedback on. So your hands are a little bit tied because if parents are not on board, parents play such an important role in anything that you do. Obviously, you have him for somewhere around 30 hours a week, which is quite a lot in school, but having said that, it's really important for parents to get on board with this as well. Now, you can still make a difference. You can change things in the school environment. It'll just be a little bit tougher because he'll have a very strong contrast to what he's allowed to do at home and what he's allowed to do at school. My feeling about the whole thing is that it doesn't really matter what country he's from or what the cultural background is. The fact is that he now lives in this country, and so we have a set of rules and guidelines that we have to adhere to in this country. It just is. You know, if we all lived in a nudist colony, it would be perfectly fine and we'd have different criteria for him, but we don't. We live in this society, and it's important for him to fit into this society, which is why I would, you know, you're a teacher, and I don't know how much ability you have to try to modify the behavior at home, but I would really recommend that you do have a conversation with parents and that you try to get a supervisor, BCBA, or someone who's a behavior analyst, have a deeper conversation with parents. It's very important. The concept is he may be doing these things 3 now, and he's, you know, it's not such a big deal. It is already to me a big deal, but it might not be a huge deal to the family right now. obviously it's a big deal already to you. And so imagine if this behavior continues and he becomes 7, 8, 10, 15, you know, how inappropriate would it be then for a 15-year-old to be running around naked playing with himself? So the sooner we get on this behavior, the better it is. So that's number one. That's the first thing, is that you have a very reasonable request, and I think it's a very appropriate thing to deal with, and we need to deal with it now. And ideally, you'd want to deal with it in all environments. Now, secondarily, let's talk about the anxiety and how this affects the anxiety or not. It doesn't really matter. It may reduce his anxiety. When I do a lecture on anxiety, I always talk about that we all have a lot of different things that we do to reduce our anxiety. Some of them are healthy and some of them are not healthy. For example, sometimes people get very anxious and they'll overeat. That's not a good thing.
Pick me.
Okay.
I'm familiar with that one.
So that's not a healthy coping mechanism. Others may, in anxiety, just go and shop like crazy, or others may, in anxiety, drink more, or whatever it is. These are not good coping mechanisms. So, and as a whole, they're not acceptable because they harm you, even though they might be what I call short-term solution. In the long run, it's harmful to the individual. Another very good example that we experience all the time is when parents allow their children to sleep with them when they're very young, and this behavior continues because the child comes in, cries, and battles and so on in the middle of the night, and nobody really wants to deal with it. Or sometimes it's just because the parent feels worried or anxious. It's all the things that we let our kids do once we say, oh, the child has diagnosis of autism. We just say, oh, maybe I should just embrace him and spoil him and let him do all these things because he has autism. And it's the same thing. It's kind of like it's reducing our own initial anxiety because we feel like we're doing something about it, but in reality, we're harming the child long term. So it doesn't matter if this behavior is producing some form of relaxation for him. The reason it doesn't matter is that it is an inappropriate out. It's an inappropriate solution to the problem. So let's assume that he has, which clearly from what you're telling me is, he really has a very significant amount of anxiety where it's showing that he'll cover his eyes and he'll be shaking. Having said that, it could also just be avoidance. I don't want any demands placed on me, and so just leave me alone. But regardless, let's assume the child has a lot of anxiety about being in school or other scenarios. We need to give him a more appropriate way of handling the anxiety. So number one, we need to get rid of this behavior that he has currently right now. And number two, we have to, as we do that, we have to remember to give him some other form of behavior that can help calm him during anxiety, moments of anxiety. Now, let's talk about the second one first, then we'll talk about different things we can do to intervene here. Teaching a child techniques that will help them with anxiety, there's a lot of different things, and it really differs by child. So often what we do is we'll produce a very cozy, comfortable corner. You'll need to get a very large bean bag that you put in a corner for the child. Perhaps give the child headphones, noise-canceling headphones preferably. Identify some type of auditory music or story or something that he likes to listen to that is calming. You can also find books, something on a computer for perhaps programs or games, things like that. With children, most of the time, you can certainly teach him. He's very young. You could certainly teach him just breathing exercises. So that's just like, as soon as you see him getting anxious, you will sit down and have him model like, and you'll count for him deep breaths, and that automatically will reduce anyone's anxiety. But with children, most of the time, the way they self-regulate is distraction rather than relaxation. They don't get into relaxation until a little bit later in life. Their anxiety does dissipate if they're able to distract, and the way to distract is with things like putting on a set of headphones, listening to something, or watching something, and that will definitely distract him from anxiety. That would be an appropriate way. Running, any kind of exercise, jumping on a trampoline, that sort of thing tends to also redirect anxiety. It just puts you in a different mode when your heart rate is higher. So there's a lot of other things. He's very young. Later on, I mean, if he's a little bit older, you can teach the child various tapping techniques and things that are distracting for anxiety. Now, but playing with himself is not an appropriate thing. So let's talk about how to get rid of this behavior. You know, the easiest thing that you could do is the combination of two things. One is that you basically, and a lot of it is just going to be antecedent control. So you're not going to be punishing him when he does this, you're going to be trying to block this behavior and immediately replace it with something that's incompatible with this behavior. So the way to do that is, there's two ideas I have right now. One is, when you, first of all, ask the parents to buy him like 5 sets of overalls. Okay, so not pants, but overalls, so that he actually can't physically touch himself. He may be able to over the overalls, but he won't be able to pull his penis out and actually start to play with it. So that would be important. And once he has overalls on, obviously we're helping him. Well, he's not able to access. I don't want to forget that there's something else I want to say at the end too. But so that's one thing, is to block it at all times so that there's no contact. Now, it'd be very important that parents also have him in overalls at home or onesies at home.
I was just going to say, for some kids are clever with overalls and they can get both hands in through
into
the sides.
Yes.
But they have coveralls that, even for little kids, that, you know, zip up or button up, that gets rid of that too. So depending on how he does, yeah.
Absolutely. And at home, of course, they could use onesies that are like more like pajamas. Now, in addition to that, as soon as you see his hands approaching the area, you want to block it. In other words, you'll go immediately up to him, get in his face and say, no, let's do something else. And you give him an object. Because if his hands are busy with an object, obviously he's not able to do that behavior. So his hands need to be occupied. In fact, if you want to, you can, across all time frames, you could have him hold an object. So you could have, perhaps you look and see what situations there's a higher rate of this behavior occurring. Is it throughout the day? Is it an equal amount throughout the day? Is it in certain scenarios? Is it when demands are placed? Figure out the time frames that it's happening more, and you will have him perhaps hold on to a laptop or an iPad or a notepad with a drawing or a pen or some sort of like a toy or item that will otherwise distract him, which, by the way, a lot of those types of like koosh balls or things like that are stress balls, those types of things will also give the child a sensory type of reaction, and they like that, and often kids will use those things much more. So essentially what I'm saying is, give him something that he likes to fidget with, and that will be something that'll distract him. Make sure that you're able to take the item away when you're actually teaching him so that he's able to focus and pay attention. So what you're doing is you're preventing it, and you are now giving him an object to just keep him busy. Now, the component that needs to come into place is you have to reinforce him, and I would reinforce him on the contingency that the behavior is not occurring within certain durations of time. So essentially you would time, let's say, you would look at it and say, right now, he's doing this behavior on the average approximately 5 times an hour, whatever it is. You time it and you observe him during the course of the day, and you say it happens, and then the next time it happens, and you get the duration, the frequency of amount of times he does it in a certain duration of time. You get that, and that's your baseline, and now anything better than that you reinforce. So let's say it happens like every 10 minutes. If it occurs every 10 minutes, what you're trying to reinforce him now for is not doing it every 10 minutes. Okay. So what you look at is, you put a timer, and if he's able to not do it for 10 minutes, you give him a major reward, whatever it is that he finds reinforcing. And you just do that for a while, and then, like, let's say the next week you'll make it every 11 minutes, and you do a very gradual increase. If he does during the 10-minute period and you have to redirect and block, then he just doesn't get the reinforcer for that period of time, and you reset the clock and you do another 10 minutes. So your goal is always to increase that baseline of not touching himself from 10 minutes up, from whatever his baseline is.
If you find that he keeps doing something before you get to the reinforcement, can you pull it
Reduce
back
the
to 8
duration.
minutes?
Exactly.
So that he sees what it's like when it doesn't happen.
So you
Okay.
reduce the duration. It really, that's why it's so important to get the baseline right now. So you'll get that in place and you'll figure that out, and then you will be reinforcing him very frequently for not doing this behavior. And then other than that, the only other big thing I want to mention here is that he's 3, he should be potty trained. So you mentioned that he's in diapers. A part of this could just be the sensation of the diaper as well. And it would be important to get in an ABA group in there to help potty train him, because that is an important thing. It might just change things for him.
Amazing. And, so interesting. And I want to encourage you to write back in if you want clarification on anything, or as it goes along, if you hit a stumbling point where you need some more support,
please do.
Please write back in.
Yeah, and one other last thing is that a lot of times parents will actually, this is not something, you're not the first one to bring this up, because if not to this level, a lot of little boys will often like fall on the floor and start rubbing themselves and so on, and that's sort of a self-stimulatory behavior. And what you do is, it's very simple. It's a pleasurable experience that they've figured out and they want to do it, and they don't realize that it is inappropriate. So in his case and any other child's case, the behavior can be allowed in privacy at small amounts during the day. In other words, you would limit it and say, you can do this behavior, give it a name. Only at night when you're in your bed before you sleep, and you allow that, and outside of that, it's just not allowed.
I want to go back briefly on something that you said, because it just struck a chord with me. The whole idea that I talk a lot in parent groups about how we get used to a new normal as parents, that we, even though if you had asked us 10 years before if this was acceptable, we would have said no.
Right.
When our child is diagnosed with autism, we get into a mode of, well, he's clearly so anxious and I don't know exactly what to do, so this is my new normal, that my child can do X, Y, Z, and we sort of accept it. Almost like we're in a relationship with a bad alcoholic. This is just our new normal,
it's so
right?
True. So true.
And I really heard when you said, just because he's having anxiety about this doesn't mean we don't treat it.
Yeah.
That doesn't mean that we completely ignore the anxiety, and you gave strategies for the anxiety, but the excuse of, well, when we change this, it gives him anxiety, that's not enough of an excuse to not target something and see improvement with it.
Absolutely.
I want everybody to hear that, because I needed to hear that today.
Yeah, it's very important. If you think about it with yourself too, it's the same thing. It's like we might have stressful days, or I know I do this. I'm like, okay, my thing during Lent every year is not to eat after a certain time, like after 7 p.m. I don't eat at all, or 6 p.m. And it's hard. You don't realize how hard it is. And sometimes you're exhausted and you go home and you don't have time and it's late and you're like, oh, I'm too tired to do this to myself. Yeah. So you make excuses for yourself, and the fact of the matter is there is no excuse. It doesn't matter. It doesn't matter if it calms him. It doesn't matter what kind of stimulation. It is not accepted by society. And all things for our kids, like all of our kids, no matter what level of, that's why I always say, make the environment less stressful so that you can impose these strict guidelines on the child. Like if it's a child who's extremely hypersensory, then make sure he's not exposed to heavy lighting or sounds or whatever it is, because at that point it's not fair to expect him to not do things that are inappropriate.
Right.
And once you're able to actually make sure the child's in a good place, then you can absolutely impose the same rules.
But that means we have to be willing to deal with the anxiety.
Totally.
It
Or,
means that
or
we have
any
to,
reaction.
right? It means that we have to be willing to follow through with the intervention, and it also means we have to deal with our own anxiety.
So true, Shannon. And so, like, it's the more we talk about this, it's more comes to me from you. Like, why would we assume that the child with autism has more anxiety than any other child? Any other child, right? So any other child is going through the same circumstances, but yet we think, oh, if I stop my child, he's going to have anxiety. What about any other child?
Yeah.
Every other child has anxiety when they go to school. Every other child has anxiety about new friends. But we expect from them and we teach them coping mechanisms.
Yeah.
Same thing with our kids. And I always say this to parents: if you expect your child to fit in or to become normal or to behave like other kids, the contingencies have to be the same.
It's in real time. I want to move on to the next question. My son is autistic, 5 years old. He has few words here and there, but he is not verbal yet. Will he ever talk? I am very lost, but I have hopes.
Must be so scary for parents. Yes, obviously I can't answer this question because I know very, very little about your child. I have had 5-year-olds who started therapy at 5, who were nonverbal and recovered. So I can tell you that. I know a lot of children who are nonverbal until 4 or 5, just because they haven't had intervention. So I don't know if he's had any ABA, but before it gets too long, like today, you need to start figuring out a way for him to get some intensive ABA. It depends on where he's at right now. Being able to verbalize is not the only thing. A lot of times children won't verbalize, but they're highly, highly intelligent and capable, and they're trying to communicate in other ways. So it's just an important thing for you to get an assessment. Maybe you can write back in and tell us what you've done so far, or what his placement is, where is he, what kind of services does he get, and tell us a little bit about him, like, what are his skills, how does he communicate his needs, what does he like to do on his free time. Those types of things would help me a little bit better guide you.
Okay, and wonderful. And I love that you said, sometimes we have to adjust our thinking about what steps and what's important. It's
Yes.
a hard thing
Yes.
to say, and no one would ever tell you to let go of the wish for your child to talk, because that'd be impossible, right?
Right.
But in the realm of things, you want to get that functional communication going as soon as possible, because your whole world will change when that happens. And we know statistically that if you get the functional communication on board, your child is more likely to talk.
Oh yeah, there's no question about that. Absolutely, I totally agree. I mean, talking and verbalizing in any way, or even communicating via an augmentative device or sign or PECS or whatever, will only develop when the child has figured out that it's useful. So it has to be functional in the sense that, language, to us it comes naturally, but to many of our children it comes to them when they figure out that it's useful, it meets their needs. So it has to be functional before we do anything about it. Now, so that's definitely. A lot of times, though, parents just think that having language is the only thing they want, and it really isn't, because sometimes your child will develop a certain level of communication later on, and it's adequate, it's enough. What you really are looking for is being able to express yourself, for the child to be able to express themselves somehow, whether it's verbal or nonverbal, doesn't matter, but it's important for them to be able to express themselves so that they don't start to develop other behaviors that can be harmful to others and to society and to themselves. Aggression often forms when we can't express ourselves and we become frustrated. Any kind of aggressive behavior or tantruming, a tantrum really is the child just saying, I'm upset that I can't have this object, or I'm upset that I have to stop doing this activity, or I'm mad at you because you said no, or whatever it is, or you're making me work too hard. Tantrum and aggression or any kind of challenging behavior is really all about just expressing frustration. So being able to express frustration in some other more appropriate way, vocally or non-vocally, through an OG device or a visual program, is really important, because it gets our kids to be less frustrated, it gets them to express themselves, it gets them to not act out in society, to be more part of society.
And I want to piggyback on this, because we had another question come in that I think is from another viewer, but my son is 5-year-old, has limited speech, but improved in the last year where he was completely nonverbal. He's receiving 10 hours of home ABA service since he was 4. We are going to move him from public school to card very soon. Can I still expect my son to recover, catch his peers, as he is already 5 years old? Kind of goes hand in hand, but this person is making the decision to say, okay, I'm not doing public school anymore. I'm going to go to the creme de la creme and put my child with card, which I think is the best possible circumstance you could give that child.
It is a fabulous situation, and I'm assuming you're in one of the areas where we have a school, an academy, and he's joining our academy. I'm not sure, but it's important to review this, because we review these research findings often with our staff and with our families, and it's really important to discuss these for a minute if we can, Shannon, because in the last month or so we've submitted for publication a few studies that are, I think, really change the face of ABA to some extent. There's several studies that we've done. One study, and it's great that your child's making progress with 10 hours. Let me start there. Because if a child makes progress with 10 hours, that tells me that they're like a sponge, really needing ABA. That ABA is their language, and it will work for him. Now, multiply that by 4, he'll be learning way more if he gets 40 hours. Now, on that subject, I also want to go back and say, it's funny because I think I mentioned this last time that we were talking about, we're writing a standards paper, and I was looking and thinking, where did 40 hours come from? And we realized, and I was saying, Ivar Lovas used to always say, it's just the child's waking hours. So we're supposed to be doing these interventions with a child from the time he wakes up to the time he sleeps, all day long, every day. And the 40 hours was not meant to be including everything. The 40 hours was supposed to be only the hours that the parent is not with the child. So they're working, for instance, and that we are able to cover the child. So in reality, 40 hours should be, now it's like the upper limit, and no one ever does anything above 40 hours. Whereas in reality, 40 hours should be the lower limit, and it shouldn't really, to be honest, include school, unless the school is doing a full-on ABA type program, and a lot of schools are not. So in reality, the 40 hours should be on top of school, and it should be, every waking hour should be therapy, which is why it's so important for parents to be trained. And we were training parents all the way back into the 70s. It's important for parents to continue this when therapists are not there. That aside, that's one thing we've discovered, is that all variables, everything you can imagine, the child's age, the child's illnesses, other medical illnesses, the child's diet, amount of sleep, who the therapists are, who the supervisor is, what is the content, nothing, all those things put together do not equate to one factor alone in terms of how your child does, and that one factor alone is just hours. It is just hours. So I can't express how important that is. I keep saying this because parents really feel that if they do 10 hours, it's something, it's good, 15 is better, 20 is better. Yes, to some extent that might be the case, but you might be missing the mark. And it's your child's life, and I don't want to put more pressure on parents, obviously, but these types of things only ever change from the parents, parents pushing. And please, as a parent, if you're watching, please don't allow this field to be watered down. 10 hours is not the recommended dose of ABA. 40 is the minimal dose of ABA that is effective. We've done these studies over and over and over, and it is important to be doing more hours rather than less hours, because your children need this. It's the single factor that has the highest relationship to positive outcome. So the more hours, the more likely your child will do well. Now, our other study that we recently have submitted for publication is that it showed that if you are receiving services in a controlled environment, in a center, in a clinic where there are supervisors present, where there's staff always available, and there's groups of other children receiving similar services, your child does a lot better, up to 85% better, in fact. Parents often now ask me, why is that? And I just have to guess why that is, because we didn't look at why it is. We just contrasted kids who were receiving in center to kids who were receiving in home. And we also contrasted kids who were receiving services in both environments. And we saw that in all cases, the children are doing way, way more learning, 85%, 80 to 85% more learning when it's at a center. And so, I think if I want to think why that is, I think it's because the supervisor is there, because you're more focused, there's much less time wasted, it's much more efficient, and so on. So if it was me, I would definitely fight for my child to get the best, which is more hours, and at a center. Those two factors are very, very important. Today I was announcing to our staff some research that we also looked at, and it does actually make a difference if you have a supervisor who's board certified. I think it was pretty high amount. It was 70-something% more learning when the supervisor is a BCBA versus not a BCBA. So that's it's a strong compliment to the BACB in terms of having regulated our field well. Good for them. Honestly, kudos, because what a great job to produce a credential and then have all these universities adhere to a set of learning principles that produce really qualified people. So I think that's a fantastic finding as well.
Absolutely.
These are important things. It's just important for us to not forget that all of our kids have a lot of capabilities, and their chances to recover or catch up with their peers increases exponentially with every hour of therapy. And again, if it's center-based, if you have a supervisor who's board certified, if you are following a curriculum, that's good. If you have dealt with other issues for the child, like if the child's not sleeping, help them with that. If the child has medical illnesses, help them with that. All of these factors contribute to the well-being of our kids.
Yeah, people will tell you that there's a lot about autism we don't know, and that's true, but we do know what the prescription is. It's not easy to follow the prescription, but it's important to follow it. Okay, here's a question. Where can I find help for myself as an autistic adult? I went to the County Development Disabilities, and they told me I was too high functioning for them to help me. This is a sad, sad tale that we hear a lot. They referred me to a place that doesn't treat autism, just addiction and mental illness. It seems that all of this help for autistic people is explicitly for children. And I know that it seems that way, but that isn't the entire truth. It's just that there isn't as much for adults. So what would you like to say, Dr. Granpeesheh?
Oh gosh. Okay, so these are my thoughts on this. There's a lot of different things about this. One is, the County Developmental Disabilities is not the best place to start. For you, what I think you should do is you need to find a psychologist who is somewhat experienced in autism. So that would be someone like me. Because you need to start with someone who can identify a diagnosis, for lack of a better word, because without that diagnosis, it is unclear where you're going to get assistance or what type of assistance you're going to get. Now, the diagnosis may be ASD, very, very low severity, or it may be sub-factors of ASD. So don't forget that autism kind of is it's a conglomeration of a series of symptoms. Like, for instance, you must have the social deficit and the language deficit and sort of like a repetitive behaviors, and you have to have X number of symptoms in each area and so on. But in reality, you might have one or the other. Now, in the past, we used to say kind of if you just have a lot of the social issues, then it's more Asperger's, or it could be PDD. It depends. But right now, what I'm saying is, let's look at you have to find someone who's a psychologist who can kind of just meet with you, chat with you, and see what your diagnosis could be. Like you could just have a social problem or a deficit in social skills, and that's its own diagnosis. And then from there, it helps to identify the treatments that would be beneficial for you. I can tell you that if you're dysfunctional and this high functioning, you're not really looking at, I mean, to some extent, you will be having some ABA techniques, but it's more cognitive behavioral therapy that you're looking for, because cognitive behavioral therapy is when the psychologist or the behavior analyst gives the person a series of techniques to practice in their own mind and in their own lives. And these techniques are often behavioral techniques. But the reason we call it cognitive behavioral therapy is sort of you internalize it, you take it home and you practice these things, and you gradually, you do homework, you write these things out for yourselves, how to improve and so on. We all practice a little bit of cognitive behavioral therapy in our lives. We all practice a little bit of ABA in our lives. But it's in your case, it sounds like you would need someone to help structure that for you. And so really, the only thing I can tell you is I don't know where you are, but you would need to find a psychologist who can help assess and diagnose and give you a clearer picture of what the issues are, and where you need help and what type of help you need.
And I just want to say, if you didn't catch last week's Let's Talk Autism with Shannon and Nancy, we had Emily Island and her son, who's an adult on the autism spectrum, Tom Island. He's a CPA who's now a speaker and speaks all over the country about autism. And one of the questions that we asked was, what really helped you? Tom wasn't diagnosed until he was a teenager. Mm-hmm. And he said personally for him that cognitive behavioral therapy was one of the things that helped him the most. So you can watch that interview. It was during Let's Talk Autism last week, and there's a clip of it that says what therapies worked. Tom Island and Emily Island, what therapies worked, to hear him talking about that. Okay, moving right along. Okay, dear Shannon and Dr. Doreen, my son's school thinks he is ready to have his one-on-one aid at school start to fade out. He's in first grade. I'm not sure, since he still has behavior incidences at recess and gym with not regulating his emotions. What data should I ask for to show me he's ready to have less support? Should his IEP change? And she said, excuse me, thanks for your help. I'm excited for him, but also a little nervous too.
Yes, absolutely. How old is he?
He is, she did not say. He's in first grade.
First grade. It's a little early for first grade in my mind. I very rarely would have faded out a shadow in first grade. Usually it's closer to the end of first grade or even second grade. So I think what you're looking for is if you have a provider, if you have a behavior analyst who's working with your child, or you have an ABA program and someone who oversees that, I think it's their decision. They would have to come and do an observation. If it was me, this is what I would do. I would send an unknown person to the school, so someone that my child doesn't recognize, who can do a very good evaluation or assessment of how my child is doing in every section of the day. Sometimes our kids do really well when they're regulated in the classroom, but not so well during recess. Like, it's important to make sure your child's doing great during that time frame. Then I would fade the shadow. If I felt my child is doing really well, I would fade the shadow from all very regulated areas first, so classroom settings where the child is doing really well, and then from social settings, where often our kids need a little bit more support, and I would do that over the course of a year. I would do it very slowly. So please watch for that. You're looking for, obviously, the child being able to express themselves, follow all of the instructions of the teacher well. You're looking to make sure the child never feels lost in those settings, that they're academically keeping up, they're learning about the same pace as everyone else. You're looking to make sure that your child enjoys going to school, is happy to be there, has friends. During free times, you're looking for really not being able to tell the difference. If the child is interacting with other kids, they should be about the same level of interaction as the other kids, same level of verbal interaction, nonverbal interaction, so on and so forth. So a lot of that sort of stuff is what you're looking for, but I would recommend that you get a professional to go in and observe. A lot of times the decision is influenced by, and I don't want to say in this case, sometimes it's influenced by financial reasons, where the school feels that the sooner we can cut this aid, the less we have to pay for this case. And that shouldn't be a valid reason. So, make sure you have a kind of objective outsider take a look at the situation.